Hello, my name is Dr. Richard Chanik, and I'm joined by my colleagues Dr. Vic Tapson and Dr. Rajan Sagar. The World Symposium on Pulmonary Hypertension recently redefined the definition of pulmonary hypertension as a mean pressure over 20 millimeters of mercury, where previously that cutoff was 25 millimeters of mercury. So we have a new group of patients between 20 and 24 that now meet the definition for pulmonary hypertension. Clearly, with that change comes the question, should these patients be treated? How should we approach these patients? Raj, let me start with you. The concept of risk assessment, determining low risk, intermediate risk, high risk, is something else that's been really stressed in the World Symposium. How does that approach apply to this group of patients in that 20 to 24 range? And how would you approach such patients?
Well, I think it's a great question, Rich. First inclination is to think, well, this must be a low-risk feature, having a pressure of 20 to 20, between 20 and 24, and by definition, they must be low risk. But I think they're probably two separate topics, and the risk assessment is frankly unrelated to the actual pressure assessment. So I think we would still risk stratify the way we sort of always have, but we're taking into account now a newer population, a population that we weren't really addressing before, and simply applying the same risk stratification tool we did before to just patients who have an earlier, or I should say, a phenotype with less mean PA pressure.
Yeah, absolutely. And the other important, I guess, concept that we should emphasize is that there's a PVR part of that definition as well, and that may affect severity and risk stratification to a degree.
Yeah. So when I sit back and think about just all the cases that we've seen over time, and try to think about that, certainly we have heart catheterizations where we end up with a mean PA pressure of 21 to 24. And when I think about those patients, I'm hard pressed to remember cases, or that many cases that had a pulmonary vascular resistance greater or equal to 3 Wood units. So I think the symposium and the minds that put this together were cognizant of the fact that it wasn't just the pressure that they were interested in, but it was the pulmonary vascular resistance, and making sure that this was at a level that warranted consideration of therapy.
Yeah, and I guess an example of that kind of patient would be, I've certainly seen patients who are, let's say, pretty dry, and you get these mean pressures in the low 20s, but their outputs are low, and their wedges are quite low, so their PVR actually does come out to be elevated. And you've, in the past, always wondered what to make of those kind of patients.
Yeah, that's a good point.
So again, that gets us to the next question is, if these patients are considered low risk, I agree not all of them are, the PVR may be important, in the treatment algorithm, we're really recommending fairly aggressive therapy, even for patients in low or intermediate risk. Does that apply to this subgroup of patients, do you think, Vic?
Well, I think it's going to have to now. I think the key is we don't have data in these patients. We really don't have data, but I think what I would say as a clinician is, again, as Raj suggested, most of the patients we see with a pressure of between 20 and 24 are probably going to have may often have a normal PVR. When they don't, well, look at them like any other PH patient. Are they going to be low risk? I think a lot of them will be. We talk about risk, we're talking about the Swedish registry, the French registry, the Compare registry, the Reveal risk score. And for example, is a patient with a PA pressure between 20 and 24 going to generally have, and a PVR greater than 3, they're going to probably be functional class 1 or 2. They're probably going to have a walk distance greater than 440. They'll probably have a normal BNP. I suspect, and those are some of the key features of these, of our risk stratification from these registries. So I think, in a nutshell, if they meet the criteria, I'm going to want to treat them. And how will I do that? I suspect what I'll probably do is start with monotherapy in some of these folks. I don't think I can extrapolate 2-drug therapy, upfront combination therapy, we call the Ambition protocol, to these patients, but I will individualize them.
Would you have a similar approach, Raj?
I think so. I mean, I was just listening to what Vic was saying, and I agree with all of that. I remember when we were trying to enroll in the early study, which was, to remind everyone, was a study of looking at bosentan in the setting of functional class 2 patients. And enrolling in that study, because it required you to meet the definition of PAH with this PVR greater or equal to 3 Wood units and the mean PA pressure greater or equal to 25. And we were hard pressed to find those cases. Often it was tough to find cases that met that PVR definition and have functional 2 symptoms. So it I think there's going to be a learning curve here to understand who this phenotype or which patients actually fit this phenotype, and who deserves a trial of therapy. I think one of the key messages I think would be important is I think a trial of therapy is reasonable when you have a pretest probability that's high, but if it doesn't work or there's not objective improvements, that making sure we remove those therapies and not just leave patients on therapies indefinitely.
Yeah, I think that's a great point, and maybe also endorses the use of cardiopulmonary exercise testing as a way to objectify. I know in my practice, I'm treating these patients who are, let's say, more mild or low risk, but they're symptomatic. I really like to have data, as you say, to show that the medication is working, and getting objective CPET data at intervals sequentially, I've personally found it to be very helpful in making that determination as to, are you really improving anaerobic threshold, all the VEV CO2, all the parameters we look at in exercise testing as an indication of pulmonary vascular disease.
And I suspect also, Rich, that we're not going to see so many of these patients it's going to cause a big uproar. Right. Patients with mean PA pressures 20 to 24, PVR is greater than 3, where our clinics are going to be overloaded. I think it's going to be kind of rare folks. We're going to have to think carefully about them like we often do in PH and individualize them.
Yeah, I think that's exactly right. They need to be studied in greater numbers, and for now, sort of a case-by-case basis in this sort of newly found patient population. Well, that's all the time we have. Thank you very much. Thank you.